had 2 MTHFR mutations, and I also had a blood clotting disorder that even if we were able to get pregnant on our own, that presented a whole host of problems. So logistically, we had quite a road ahead of us. Before I met with Dr. Silber, I met with Dr. Pineda, who is our reproductive endocrinologist, and he was the gentleman who explained everything to me and basically said that we could continue to try on our own, but if we were able to conceive, we would most likely only have 1 child. And because we knew that we wanted to hopefully have more than 1, the best opportunity for us was to go through IVF and try to bank our eggs and our embryos before my ovaries quit functioning altogether. So that was the approach that we were able to take.
That is a fantastic explanation of it. It's really an amazing story. Yeah, you were always lovely people to take care of, but you were a nightmare, that's true. So with really low ovarian reserve, very few eggs left, and eggs that are acting like they're 44-year-olds instead of 36-year-olds, what are you going to do? So this is an amazing couple. I mean, they get the credit because they went through multiple mini IVF cycles to store embryos. Maybe tell them a little bit about that, and I'll explain why mini IVF was the only way to be successful with you.
Sure. So one of the things that I loved about Dr. Silber was his methodology. His methodology was more, especially for somebody in my situation, was instead of blasting my body with a gazillion pounds of drugs and medicine, was to use the most minimum amount we could use and try to get the best response, which means basically just get a couple healthy eggs instead of trying to get 30 and still try to end up with the same result as somebody who would have gone through a full IVF cycle. So we went through 8 altogether, 8 IVF retrievals. Our hope was to get 2 to 4 eggs each retrieval. And we were hopefully trying to just go through a couple of retrievals, but I had a pretty low response to the medicine. So
she was a poor responder.
Yes, I was a poor responder.
One
My
of these
ovaries
people
were not
would have
cooperative.
normally been canceled in a regular IVF cycle.
Yeah, like I said, most doctors would, especially doctors who are all about the statistics of their clinic, would have ran from me because it was not in their favor to treat me. But Dr. Silber saw the possibility and never once told us anything but this being a possibility for us. So maybe I was naively hopeful, but it worked to our advantage.
Fantastic.
Our goal was 10
Yeah.
to retrieve 10 eggs, and there were several where we had 1 or 0, and so it was quite frustrating to sit on the sidelines and wait for that to happen.
Yeah.
But just we kept at it, and with Dr. Silber's help, we hit our goal, and about 2.5 years later, we finally got the reserve that we wanted, and we were blessed to be able to transfer them.
But that was the glory as well with Dr. Silber. If we did not get the result that we were anticipating, he immediately changed the protocol, and we tried it a different way. And out of all 8 IVF retrievals, we only duplicated one retrieval process the same.
Yep.
So, and that was the retrieval that we actually ended up with our child. So it worked out really well.
So the whole idea here is that there are many couples where they're advised just to not do anything because they're worried about statistical reporting of success rates. And if there's any chance of getting pregnant with their own eggs, most couples would prefer to do that. And this minimal simulation approach allowed us to get the best quality of eggs. So she was really a poor responder, but it didn't matter because if we had stimulated her with huge doses of drugs, we wouldn't have gotten any more eggs, but they wouldn't have been any good. So, so tell us about when we did get a success, what it was like, the transfer.
The transfer itself,
Yep.
honestly, I think this process, this facility is such a well-oiled machine. I actually have to back up and give props because I had done a lot of research prior to this and during this. We both work full-time. I don't anymore, but during this process we did, and that's one of the ways, unfortunately, to pay for it is you have to work to be able to afford the process, because it's not the least expensive way to have a child by any means. But this clinic, in this facility, in the hospital, I never once had to miss a day of work. The blood lab opens at 6 a.m. The ultrasound opens at 6:30, 6:45 in the morning, so I was able to get to work by 7 o'clock and go back to my normal routine. And that's what is so glorious about this whole process in the mini IVF is, even though it's invasive, you still go back to your normal life, your new normal during the IVF process, because it is a new normal when you're going through this. But
I forgot whether, did we do your transfer on a Saturday or Sunday? Or,
well, that's the other part of it. So because I was such a low responder, by the second cycle, we were able to figure out how I would respond, and I could say to my coordinator, all right, Fridays are my day off, so let's shoot for a Friday. And I never once had retrieval other than on a weekend. So it was pretty. I mean, that's that's the sad part about doing 8, is that you can actually figure out how you're. So yeah, you just sit on the couch for the weekend after transfer. The transfer that's the easy part, except for having a full bladder, which I know that sounds crazy, but that is probably the least comfortable part of the process. But
the reason we have a full bladder, we're not sadists, but so that we can see your uterus
the best
from
technique.
above
Yes.
when we put the.
Yes, it makes for an easier transfer, but
And the transfer is really, really important, because if you irritate the uterus when you're doing the transfer, or have to resort to a stiff catheter, then that will lower the pregnancy rate. It's got to really be extremely delicate. So remember asking you to relax.
oh yes.
How offensive it is to someone, just tell them to relax.
Through the whole thing.
Yeah.
They always say stress doesn't help the process. Well,
So what we do is
Easier said than
we tell you to relax your body muscles,
yes.
because that you have control over.
Yes.
But I would never tell you to relax otherwise.
It's a short process, and that honestly is the easy part, and it's amazing because you get to watch your potential child at the start of their life, and from the moment that they're put inside of you. That is, I will say, one great thing about this process is I have a picture of my child as 8 cells, and how many people can say that they know the minute that their child was growing inside of them. So
That's
pretty
why
cool.
the nurses really cower when I say this. It's my joke, but it's true. I think this is the most romantic way.
Definitely.
Because you're really into it together. You're really.
Yeah.
It's
All you're
not just
thinking of
a
is when can I go to the
moment.
bathroom?
You get to see conception.
Yeah. Yes.
You are getting a few questions, so I want to interject a little
Okay.
bit. Chelsea would like to know, have you helped with a husband having hypogonadism?
Hypogonadism? Maybe?
Yes, that's
Okay.
hypergonadism.
So what
I'm sorry.
hypogonadism means, it really means that he's doesn't have, well, there's 2 types. There's hypergonadotropic hypogonadism, which you don't have to remember that word, or
spell it.
hypogonadotropic hypogonadism. Either way, the testicle is not making a lot of sperm, or it's making no sperm. Now, one of the common causes of that is the pituitary gland just isn't stimulating, and so there's no FSH or LH to stimulate the testes. And the other way is just the testis itself is deficient in sperm production. So it's 2 different approaches for you. What was her name again?
Chelsea?
Chelsea. So Chelsea, there's 2 different approaches. If it's the pituitary isn't working, then we replace pituitary hormones, but that's never going to give you a normal sperm count. It might take 4 months and it might take 9 months, and we keep checking it. And once you make even the smallest amount of sperm, then we freeze the sperm, and that frozen sperm will be good for an infinite number of IVF cycles. It's because we inject the sperm into the eggs. We first developed that in 1993, and it really works, and it doesn't matter if the sperm count is normal now. But now, what if the testicle is just deficient and it appears to be making no sperm? Well, in 60% of those cases, with microsurgical procedure under local anesthesia, we can find sperm. Maybe a few sperm, maybe 2 sperm, maybe 5 or 10 sperm. I'm not talking about 1,000 or 10,000 or 10 million or 20 million, which are all very low sperm counts. I'm talking about 2 or 3 sperm. We can inject those sperm into the eggs and again have a normal pregnancy rate. So even if the man is not making sperm, quote, not making sperm, 60% of the time we can find enough sperm for the wife to get pregnant.
That's amazing.
So 40% of the time, if we think he's making no sperm, okay, well, we're not going to find sperm. But that's a very, very tiny percentage of patients. So we hope that you're in that. Either it's 100% if it's just the pituitary gland, and it's 60% if it's the testicle.
Okay, Kristen would like to know, why is a hysteroscopy sometimes suggested before implementation?
Yeah. So I think that's kind of a money-producing thing. Let's just do hysteroscopy on everyone. Now, the valid part... What?
I had one.
Yeah, well, the valid part of it is you want to make sure there is no polyp and nothing that'll prevent implantation. But frankly, with our 3D ultrasound nowadays, we can just screen with ultrasound, and if we see anything that looks questionable, then we do a hysteroscopy with the intent of removing the polyp. But you don't have to routinely do hysteroscopy on everyone, because modern ultrasound is just so good. But the reason we don't want a polyp is because that can act like an IUD and prevent implantation. So for sure we want to have a clean, perfect uterine lining.
Okay, Teeny says, I have PCOS, and just did our first IVF. She had 30 follicles at trigger, and they retrieved 17 eggs. Only 7 were mature, and ended up with 3 blastocysts. Are there any suggestions to improve her next cycle for egg maturity?
Right, well, this is a PCOS case, and PCOS is really, which is irregular cycles and no ovulation or poor ovulation. PCOS is actually caused by having too many eggs. Sounds strange, but it's really true. And having so many eggs that you were born with inhibits your FSH elevation in the first part of your cycle, in the first day or two of menstruation, and so you never really recruit a dominant follicle because you didn't have that rise in FSH. In fact, you normally would have a high LH to FSH ratio because your FSH is just so low, inhibited by having so many eggs, inhibiting the pituitary. So when you do IVF for these kinds of cases, you can have really dangerous hyperstimulation. I mean, 30 follicles is kind of scary because you could have a nasty hyperstimulation syndrome that can really almost be life-threatening. So we don't ever have that anymore. Now, it used to be considered normal for 2 to 3% of cycles 10 years ago, but there's no reason to ever have PCOS anymore. So what one does is, first you go on birth control pills, and we suppress those follicles, and we kill off all the, what we call non-ovulated, mid-sized, non-atretic follicles. Things that would have responded, poor quality follicles that would have responded to stimulation and give you 30 follicles, but only 7 of them even have a mature egg in them. So first we kill off all the bad quality eggs. Secondly, we'll do what I'm calling a Denmark mini IVF cycle, where we give you a low dose of FSH and a very tiny microdose of HCG. So that HCG gives us quality eggs, FSH recruits eggs, but we don't want to recruit that many. We only want quality. So with that, we could get easily 10 eggs, but good mature eggs, and you wouldn't be sick from it, and you wouldn't be spending $6,000 or $8,000 for medication. It would be maybe $500 to $1,000 for medication. And so I think we can avoid the problem you had. The reason there are so many immature or poor quality eggs is because if they stimulated any longer, they'd have to cancel the cycle, or you'd be in serious danger of your life. But when they did, most of those follicles weren't mature or ready yet, and there were only 7 of them that were mature already. And there were a lot of poor quality follicles that were that appeared with stimulation that should have been killed off with prior birth control pills.
Danielle would like to know what else besides Clomid can be taken to help with getting pregnant.
Well, okay, she wants to know what else besides Clomid. Well, Clomid is the routine drug that's given to almost every woman that's infertile for any reason. It's too routine. And it will result in pregnancies for sure, but it's a very low pregnancy rate. And that's ironic because Clomid really gives us the best quality eggs and the best quality embryos. So it's ironic that just administering Clomid has such a terribly low pregnancy rate. But it's easy to do, and your gynecologist, even your primary care private practitioner, he will just give you Clomid hoping you'll get pregnant with it without having to monitor, without having to really follow you carefully, because it's safe. But the results are pretty terrible. The reason is that Clomid has a negative impact on your uterine lining. So it has to be combined with IVF and ICSI. And if we do that, then we have the best quality embryos. But we freeze those embryos, and then we transfer them 3 months later after your uterine lining has recovered from the negative effects of the Clomid on the lining. So just Clomid alone is a terrible result. I think the next step to go to, frankly, though it sounds aggressive, is IVF.
Are there any additional risks to having a baby with gestational surrogacy?
Okay, so the question is about gestational surrogacy. So many people are confused about it. You don't do gestational surrogacy because maybe your eggs are old or your eggs are poor quality. You only do gestational surrogacy because your uterus has a problem. And so there's no problem with gestational surrogacy. It's well respected legally. The law says very, very clearly that the intended parent is the parent. It's irrefutable. So gestational surrogacy is safe legally and I think ethically, and it works. So if a woman has a terrible uterus and she's willing to do gestational surrogacy, then we're in favor of it. But most women would really rather carry the baby if it's at all possible. They would rather not have a gestational surrogate. But if that's their only choice, then it's great. Now in this country, we're very, very, very lucky because we don't have as much interference with physicians' judgment as in most countries in the world. So surrogacy is not really allowed in most places. That's why you hear about uterine transplantation, for example, in Sweden. Fantastic stuff. I mean, if anybody were to do uterine transplants, we would do it because we have the microsurgical experience going back 50 years. I mean, we're the masters of microsurgery, putting together these little tiny blood vessels. So we could certainly do it, but it's really dangerous. To have rejection possibly in the middle of a pregnancy could be intra-abdominal catastrophe, going on rejection medications that are just fine if you're having a life-saving procedure. But frankly, in this country, we have the option of gestational surrogacy. It's totally legal. Everything is accepted. And I think that's an easier route to go than have a uterine transplant. Very few uterine transplants performed. Very careful selection, immunosuppression, and it's usually, it would be a related donor. It wouldn't be like a kidney transplant from an automobile accident, God forbid, that someone died from and is brain dead. It would have to be from a donor who is known, related, and would have the least requirement for immunosuppressive drugs, because it's not a life-saving procedure where kidney transplantation, where you might be happy to get an 80% survival. To have the risk of dying from immunosuppression in a transplant, I think is really ridiculous. So we're very lucky in this country we can do gestational surrogacy without any problems if we need to.
Could you guys talk a little bit about what your process is like deciding to go through 8 cycles and how you guys kind of decided to keep going as a couple, because
Sure.
that sounds very challenging.
Yeah, actually, I think the biggest thing for us was because we knew we wanted to have potentially 2 children if we were able to. And Dr. Silber's plan for us, like we said earlier, was to try to get 10 embryos. He thought would give us the best chance to have potentially 2 babies. And you're halfway right, because it took us 5 to have 1. So, so yeah, that was the plan. And like we had stated, we were hoping to be done in just a couple cycles. But because I was a low and a poor responder, I think the first cycle we had 1 frozen embryo. The second cycle we had nothing. We had 1 egg and it didn't fertilize. It wasn't mature. So then, that was kind of a moment where you say, okay, is this something we're interested in moving forward? Because it's an investment. It's an emotional investment. It's a physical investment. It's a financial investment. But you just keep your eye on the prize. You just have to look at the bigger picture. And like I said, maybe we were naively optimistic, but We had faith in the methodology that we were in front of who we should be, and it was going to work. So, like I said, Dr. Silber tweaked each time we had a cycle. He tweaked something to try to get a better response. And sometimes we were dealing with literally 6 follicles, which anybody who is going through this process knows that most people have 3 times that much on one side. So, you know, we just hunker down, and we did. We had several. We called it "Come to Jesus." Is this something that we want to continue to pursue? And I think when it kind of hit home was, I think it was our 5th retrieval. Dr. Pineda and Dr. Silber walked out of our prep room before we were going to go in to have the retrieval, and he said, "What a success case this would be if this worked out." And I kind of thought for a minute, oh, maybe he doesn't have the I don't know, but it was a moment where, you know, again, we just kept going. But I thought, you know what, we're gonna make this work. This is gonna happen for us, and you have to have faith. If you don't have faith, it's a hard process to go through. So you just have to believe that there's a higher power and it's meant to be.
Yeah, Dr. Silber and Dr. Pineda came in, I think, halfway through, and were just beaming with, oh, this was it's a massive success. Well, we retrieved, I think, 4. we were over the moon for 4, but
we were excited to get 4 eggs.
We were elated, but we had to get to 10. That was the goal, just based on the calculations and the math. And we knew that since we had waited so long in our life to start the process, that we really had to pass go. We couldn't collect, you know, we had to go right to the end and right to the most aggressive way to do it. But like I said, we were just committed to it, and we just, with persistence and obviously the tweaking and the guidance from Dr. Silber and his team, we just kind of kept our head down and just stayed true to it.
And we wanted to get those eggs at as young an age as we could. We didn't want you just to get older and then you wouldn't have anything.
And that's what made our decision easy was...
Yeah, we had to do it all up front.
Because we had already had miscarriages, and we knew that with each miscarriage or with each failed transfer, it was 3 more months of waiting to have to start that process. And because we had waited so much on the front side, we didn't want to wait any longer. So I actually feel like we were blessed, because I've had so many friends over the years who have gone through Clomid and IUI and hysteroscopies and all sorts of treatment options and just surgeries and endometriosis. We were able to skip right past all of that. I know everybody thinks IVF is the last-ditch effort, but I feel like sometimes it should be a front line. Yes, is it expensive? Yes. Hopefully the world is changing. I think now more and more celebrities are talking about IVF. More companies are paying people to have their eggs frozen, or paying for their eggs to be frozen. I think it's evolving. So I think this is no longer something that people talk about in the back room. I think it's really going to start to change. I hope it starts to change, because I think it's a sad country that you can get an abortion paid for, or birth control, but people who fight to have a baby have to jump through hoops with adoption and the cost that's involved in trying to have a child. It's sad. I think it's a backward society, unfortunately, in that aspect.
Yeah, it is crazy. I was talking about how great it was that the legislators aren't interfering too much with legal and medical judgments. And if we make a wrong judgment, of course, we're liable, and I don't mind that, because that's sort of putting a control on the system of some sort. But it is true that the insurance system is totally ridiculous, because infertility really is a disease. It's an illness, in the sense that everybody wants to have a baby. And if you don't want to have a baby when you're 30, because it's just interfering with your busy life, sooner or later at some stage, whether you're 38 or 40 or 45 or 50, you regret that, and you want to have a baby. And one of the reasons why infertility is an epidemic around the world is because women's lives have improved. They can have an education, they're equal, and they can be in business, and they can have a career, and they can really have a life other than only cleaning house. And not that there's anything wrong with that, but they can have a life in which they contribute to society. But that creates the infertility epidemic. So if we're going to have that advance for women, then we have to have egg freezing at a young age, and we have to pay for IVF. So I agree with what you said. It's really a crazy distortion.
And I think for me too, I actually feel like I did my due diligence on the flip side of this, or on the front side, because I knew we were waiting later in life, but I had talked to my OB at the time, and I said, you know, we're starting to think about getting married and a family, and I know that my age is starting to creep up, and I know that after 30, things change reproductively. And he looked at me and said, you're healthy, you're young, you're in shape. I have women in their 40s. And there was something in me, and this is where I believe all women have a womb sense. I call it the womb sense. I knew better. I should have been a little bit more persistent, because I could have had an ultrasound to check my follicles. I could have had FSH testing at that point. And I didn't, because I trusted that the questions I asked were answered and that we would be fine. And that wasn't the case. You know,
Yeah.
it would have been just a couple simple things, and it would have changed how quickly we moved. So
It's such a misconception. We, pardon that pun, but we published a paper about 4 or 5 months ago in the scientific journals, in which we looked at 14,000 cycles, in which we could really evaluate the live baby rate per egg and figure out what is the intrinsic fertility of the human egg based on age. And there was a gradual decline from teen years to age 35, but then it was abrupt. Now, some women are really infertile by the time they're 25, and others still are fertile at 40 or 42 or 43. But if you look at the population as a whole, there's this abrupt decline at age 35. The graph is really quite remarkable. And so if you believe in the bell-shaped curve, it would be pretty smart to either freeze embryos or freeze eggs before that time. And if you want to be safe, I'd even do it before you're 30, because I don't know where you are in that bell-shaped curve. I mean, many women are going to be infertile in their late 20s even. So one thing that makes all this possible is the revolution in egg and embryo freezing. And we'll take some credit for that. It was really developed in Japan. We've had very, very close relations with the Japanese centers since 2003. And so we brought this new method of egg freezing, vitrification, to the United States, and to Europe, actually. And now it's all over the world. And that really changed everything. Now, egg freezing itself, some places it's tricky, and some places people will be disappointed with those results because it's tricky. But really, embryo freezing is very robust with vitrification, and so we can freeze embryos with impunity, and that was one of the reasons we could be successful with you. We could get those embryos when you're younger and freeze them and save them for when you're older.
Claire has a question. Could I be a candidate for mini IVF? I'm 36. I have PCOS, high testosterone as the identifier, and her husband has a low sperm count. So she'd like to know about the probability of success with mini IVF.
Well, I think your probability of success would be great. The low sperm count doesn't matter, because we'll inject the sperm into the eggs with every IVF cycle. We'll do that routinely. And sometimes the definition of low sperm count can be fuzzy or unclear. So every single case we'll inject the sperm, and we don't want to take a chance that they're not going to fertilize. Now, as for the PCOS, like I mentioned earlier, you have a huge number of eggs. And there are 2 types of mini IVF approach, 2 basic types. One is with Clomid, and the other is with extremely low dose FSH and microdose HCG. Now, they both rely on the same principle: a low amount of FSH, so that we're not over-recruiting eggs and hurting the eggs, but also an equivalent, which is very low, amount of LH effect, which in this case is micro-HCG, because that is what's responsible for the egg quality. So egg quality is the LH impact, and egg recruitment is FSH, and if you over-recruit, then you'll get poor quality. When we did that study, which we published 4 months ago, it wasn't a slight, statistically significant difference, but with minimal stimulation, the live baby rate per egg was 5 times higher than with massive ovarian hyperstimulation. And other studies have shown that. Study from Stanford showed that if you look at 800,000 cycles that are reported nationally, that the live baby rate per egg was inversely proportional to the total dose of stimulation. So, I mean, we know that that's the case, and yet so many people just will overstimulate. So with PCOS, all we want to do is do mini IVF, but the protocol I recommend is not the Clomid protocol if you have PCOS and you're 36, because there's so many eggs we may not move the needle with Clomid. So we may have to give you what I call exogenous FSH. It'll give you the same result, and it's more shots, but they're easy shots. But that's the approach I think I'd recommend if you have irregular cycles in PCOS. Now, if you have regular cycles in PCOS, then I think Clomid is fine. You'll move the needle enough and you'll get good quality eggs. But with irregular cycles, I would give you the Denmark mini IVF. We call it Denmark because our colleague in Denmark, Klaus Andersen, who's brilliant from Copenhagen, we talked about this in Denmark many years ago, and we came up with this solution for women who don't respond to Clomid.
I think that's what people need to understand with your methodology too, is it's more of a quality of eggs, not quantity. And again, we have friends who have gone through the fertility process with the standard IVF protocol at other facilities locally, and they've gotten 47 eggs out of 2 retrievals, and it took 47 eggs to have 1 baby, and we had 6 to have 1 baby.
Some have it as well.
Yeah,
Friends
so,
that have
I mean, it's not about the number. I know people get so focused on trying to get more eggs, but it really is the quality of the embryo at the end of the day.
Yeah, that's right. I can't emphasize that enough. Embryo quality is the emphasis rather than getting a huge number.
What are your thoughts on Femara or letrozole?
Yeah. Letrozole. So the way that works is it inhibits I have a joke about this, but it inhibits the conversion of testosterone to estrogen, and so therefore it raises your FSH level. It's a little different than Clomid. Clomid is an estrogen antagonist, so it tells your pituitary there's not that much estrogen around, and so your pituitary secretes more FSH and LH. Letrozole works a little bit differently. It inhibits, and I'll explain this in a minute, I've got a joke about it, the conversion of testosterone to estrogen. And in fact, that's why it's used for breast cancer. And letrozole, one of the most popular drugs now for breast cancer, to reduce the amount of estrogen. So all of your female hormone estrogen really comes from testosterone. So the difference between the male testes, it's true, but it's a funny thing, and the female ovary and the granulosa cell is that the male doesn't have aromatase, which converts testosterone to estrogen. So we just make testosterone. So my joke about it is that the ovary is a more advanced form
We are
of
so
testosterone.
advanced. We are such in every sense.
So yeah, so letrozole is I think not as good as Clomid for stimulating the ovary, but it works on a similar principle.
Could you guys talk about your process for testing and things, like how do you kind of came to all of your diagnoses?
Yeah, so that was, like I said, it was pretty quick. I had a natural pregnancy with a miscarriage that my body did not seem to want to let go of. It continued to think it was pregnant. And following that, I had a DNC, and I didn't recover well. Things just weren't right. And again, because of my advanced maternal age, I had a friend who said, you know what, you may just want to go see a specialist at this point, because we had tried for 6 months on our own, and the clock just kept ticking. So we were referred to Dr. Pineda and had a hysteroscopy just to check the lining, make sure everything was clear from the DNC. And we came to terms pretty quick, just knowing that my follicle count was so incredibly low. Just in the 3 months of testing, I went from 12 follicles to 8. So at that point in time, without knowing what the future held and what the crystal ball said, we thought within a year's time I was going to lose all ovarian function. We were fortunate that was not the case, but again, I think by the end I was lucky to have 5 follicles that were being stimulated.
And what she's talking about is antral follicles. So you see that on ultrasound any time of the cycle, not necessarily stimulated follicles. So the antral follicle count is a measure of your ovarian reserve or your potential, a measure of your resting follicles. Not necessarily what you get when you're stimulated. You'll get less than that, but you can't get more than that.
Why don't you tell them what a normal 36-year-old should have compared to
A normal 30, yeah, good point. Normal 36-year-old should have an antral follicle count of at least 20 or 25.
And I had 8, so
And
we were
you
on
down
borrowed
to 8.
time. So, and like I said, I
Well, that's
feel
right.
like
And any time it's less than 10, that really means you better move quickly.
yes,
But go ahead.
and like I said, most people with less than 10 probably wouldn't treat me, just because it's not in their favor and it's wasting kind of our time and money as well. A lot of
Yeah.
fertility doctors
Yeah.
would claim that. But like I said, we were fortunate to be able to skip some of the very invasive procedures because we had nothing to lose. We had no time to waste, so it was just going right to IVF, and we were blessed that it worked because I think the percentage for us was a 20% possibility success rate, and like I said again, we were pretty naively positive that it would work, and it did.
Can you guys talk about the support system that you had here at the office and then just externally with friends and family?
So that is one thing that I can't stress enough for anybody who's going through fertility issues. First of all, the word infertility, to me, it's like incompetent, incomplete. There's so many other in words that are so negative, and infertility is just another word. I hope at some point they rename infertility to some really pretty fancy word that means you can't have a baby without a little bit of help. You have to surround yourself by people who are going through this process or have, because it's very easy to feel like you're on an island alone, and again, you are invested on every facet, emotionally, physically, spiritually. That was a side that we weren't anticipating. You have to sign paperwork saying if you die, where do the embryos go? If your spouse dies, if you get a divorce, and it puts everything into a whole perspective because you're fighting so hard to have a child as it is, and you wonder, are you playing God, trying to make something happen that shouldn't? And then you have it in paper that makes you question it all over again. So you have a lot of gut checks through the process. So having a supportive spouse and a supportive family, and just surrounding yourself that people who know what you're going through, because unless you are in the thick of it, you really don't know. You can read about it and somebody can talk to you, but until you actually go through it and put your body through it. Again, mini IVF is so nominal compared to friends I know who go through a full-blown IVF. The medicine is less, the cost is less, the injections are less, the pills are less, so we were on the blessing side of it, I feel like, but it's an adjustment. It is your new normal. It becomes your life. You become, where can I go to do this injection? We were out at a trivia night, we had to find a coat closet to do an injection. We did injections in the car, I did injections in the airplane. It becomes your new normal. So you have to have a support system. I even joined a support group that meets at the Kirkwood Library here locally, which was phenomenal. You're in a room full of people who completely get what you're going through. They get your hormone swings. They get the bruise. They understand the bruising that you get. They understand the bloody sheets you wake up with because you had a spot that bled in the middle of the night. So they get it.
We didn't have any family locally, so we had to rely on some of these other support structures. So, Dr. Silber, Dr. Pineda set us up extremely well, kind of walked us through the entire process. But to Heather's point, just talking about it, it's at this stage of the game, other people are going through what you're going through. You just don't recognize it because there's such a stigma around it that nobody speaks to it. Just like with miscarriages, which with just the whole infertility subject, it's really suppressed.
It's kind of taboo.
Quite a bit. It's very taboo. So just talk about it, do your diligence, and you'd be amazed that you probably have neighbors and friends and family that, oh yes, I went through that. So it's just communication and the community that you support yourself with.
You need to have a community, and the coordinators here are amazing. I had Rachel was my coordinator. She hung with me through 8 cycles, which that's a lot. It's a lot of cycles. I remember Dr. Silber telling us most people at 4, they're done.
Yeah.
They don't want to do anymore. And like I said, each protocol we tweaked and changed. So every time there were questions that I had. How do I mix this? How do I do this? Which pharmacy is less expensive? And every question, Rachel would get right back to me and say, I checked the price here, go here, this is how you mix this, send me a link. She would send me paperwork in the mail. That is the starting of your support system. So the coordinators here are amazing. And anytime I had any question, within an hour I would have an email back with the answer, or a nurse would get back to me.
I think that's really crucial. I think a lot of patients would rather talk to the coordinator than me.
Yes, no offense. I love seeing you, but
I'm not
it was nice
offended,
to
it's
see
true.
you at the transfer. Yeah.
But it's really crucial that you have a system like that, because the doctors are busy. I work 70 hours a week, and we have a philosophy here that you can call us every day or 7 times a day, and you'll always get someone who really knows the answer. And if it's something they're a little puzzled about or it's quizzical, they'll always review it with me. And or Dr. DeRosa or Dr. Pineda. Dr. Pineda just retired, unfortunately,
Yes.
but we still have me and Dr. DeRosa.
They don't retire, please.
No plans on that.
We
I
still have
swim a
6
mile
frozen
every
hours.
day, and I ski and fish when I have a chance. But I'm in good shape. But the other thing I want to relate to what you said is when the Japanese first developed vitrification for freezing and developed mini IVF, which is really quite incredible. It was Dr. Kato, and it would have been in the late 90s. He said, "I want to develop a method of IVF without tears." You know, in Japanese, the translations sometimes are hard to get. You know, haiku and all that, but IVF without tears. So it's so tough what people go through. So we want to make it easier, and not to tell a woman, well, you don't have enough eggs, so forget about it, or go to donor eggs, because they don't want to hear that.
No, everybody here, like I said, we were naively positive about it because everybody else was so positive about it. And the nurses, I mean, from the minute we walked into the hospital for a retrieval, I remember, I mean, being put under the first couple times at least, it's daunting, you know, and I would say, make sure I wake up, and they would say, honey, I'm going to take good care of you. And everybody was just the class. You are in a very vulnerable situation. You go in and you have 9 people helping you to create your baby when you go to have a retrieval. I mean, it's the most sterile environment.
And your husband isn't even in the room.
Right. And it's it's sterile in all sense of the word, but everybody just so warm and inviting and just makes you feel at ease, and it's the best 25-minute nap you can have. Then you wake up and you
feel great coming out of it.
Yeah. But no, I can't give St. Luke's and Dr. Silber and Dr. Pineda enough props. You know, like I said, for a daunting, sterile process, it was about as fluid as you can be.
Well, but also I appreciate that. You really deserve great credit. You know, I think about, you said you're an optimist. I wrote in my very first book in 1979 that nothing in the history of the world has ever been accomplished by a pessimist.
It's a good philosophy.
You know, I mean, that's the only way you get anywhere.
Why do it? I mean, you know, it's too much to lose, so.
Autumn would like to know, does PCOS increase my chances of having miscarriage or IVF not working?
PCOS will increase your chance of miscarriage, because if you do ovulate, you're often ovulating old eggs that have been around for a long time, and because you haven't been ovulating regularly. And there's definitely a higher miscarriage with natural conception with PCOS. But with IVF it's possible too, but it shouldn't happen, because if you're suppressed first with birth control pills to kill off all those bad quality eggs, and you're stimulated in a mild way instead of having 50 eggs, then there's no different in egg quality. There's an egg quality between PCOS and any other case. So, no, I mean, PCOS does result in higher incidence of miscarriage, but it shouldn't.
Okay. What would you guys tell somebody considering other centers or just trying to determine if IVF is the right course for them?
Come to Dr. Silber. I've researched, I've investigated, I've read until my eyes have popped out. At least if you're in the situation that I'm in. Again, it's the methodology. I stand firm with his belief in pumping a ton of medicine is not going to get you a better quality of egg. You'll get more, no doubt. You'll pay more, you'll feel more, you'll go through more, but you're still, at the end of the day, going to put your body through a lot of unnecessary medicine and injections and time.
I guess, yeah, talking to family, friends, the support system, and just doing your homework. I mean, there's an individualized plan that they created for us as well. So although we saw, you know, a lot of family and a lot of friends potentially in here, and you kind of feel like you're coming in as part of a routine with, you know, the fresh batch that's coming in every single month. You actually have this personal experience as well. So that's really the difference we saw. And we did some research on all the other options in town.
And we visited. I mean, we didn't take this lightly.
After 4 or 5, when we weren't as successful as we thought, I mean, we were not going to kid ourselves. We started looking around to see, hey, is there another combination out here that works better for us? And we ended back to Dr. Silber. So we ultimately came back.
Everybody tends to have everybody fits in one box, and they'll tweak a few things here or there, but honestly, Dr. Silber, out of 8 times, we repeated once, and it was only because I fought to have a cycle that, was it Lupron that they were having the issue with, and then people were ovulating prematurely.
Right.
But that was the cycle that I had the best response. So at our 6th retrieval, I said, all right, here's the deal. However this one goes, I have one more left of me. I have one more fight, and I want to do this retrieval. And at first, Dr. Silber, to his defense, kicked back because he didn't want us to go through all that, to have nothing, and to ovulate early. And I said, you know what? I'm really, this is just, that if it falls on me, it falls on me. And he walked out of the room, and he came back in about 10 minutes later, and he sat down, and he said, you know what? You're my patient, and I'm going to listen to you. And we're going to do it that way. And he let me. Now, most people, especially with his expertise, would have stood his ground and said, I know what I'm talking about. You need to trust me. I do this all the time. But he didn't, and he let me have my way, and now I have a 9-month-old baby from that cycle that he tweaked just for us.
Really fantastic.
So.
Yeah, it's fertility is so unpredictable sometimes that you really have to listen to the patient's desire. So I don't want to be, you know, like they talk about knife-happy surgeons or over-aggressive or pushing people. But if someone is really determined, we go for what they think and what they feel. And it's shocking and exciting, some of the surprises we get, you know, with really low prognosis patients. We have a lot of those. People stick with it, and we get high pregnancy rates with no offense, the worst cases.
That's all right.
The nightmares.
I had the best response, so it's all right.
Well, we were looking at, I think, 15% chance with 1 egg and 30% chance with 2, and I think you were being nice to us. I think, okay. And, so, you know, with all those odds tilted against us, it worked out.
And no complications with your pregnancy? Or
I had a ton, but it had nothing to do with IVF. Yeah, no, nothing to do with
The
IVF.
delivery was actually
The delivery was the
15
best
minutes.
part.
It was the easiest part.
No,
Yeah.
I had I went into preterm labor at 18 weeks, and I had to have my cervix stitched closed, which is called a cerclage, and I was on bed rest for a couple months.
That's very, very important.
Yeah.
It's not a higher risk with IVF, but I really think it's terrible to not go to you have to go to a high-risk OB.
And that's the thing. We had a team of doctors around us. My child will know every single one of you because
if
that's the reason why he's here.
If you had a premature rupture of membranes, say at 20 weeks or 24 weeks, you'd have no baby.
Right.
But they do the cerclage.
Miracle.
And it's so simple to do, but they often don't do it. So you have to have in fact, general OBs are afraid to do it, but a high-risk OB, it's not a big deal.
Yeah, and mine, he does it again,
every day, right.
had a great team of doctors. We would not have a child if it weren't for the people that got us there. I mean, that's the reality of the situation. We were blessed.
Is there anything else you guys would like to add, or any other topics or questions you'd like to address?
That's always the last question, you know, in any interview. What haven't I really asked? Well, there's about a million things. But we're dealing here with, we've been talking about low ovarian reserve, low number of eggs, and what do we do with the poor responder? And so that immediately brings up the interesting question, and I'm not talking about today, I'm talking about some of our research, because we always want to make sure that we are on the leading edge, or that we develop it further. So what about women that they have no eggs, or they're on ovarian failure? Well, in mice, we can take a piece of skin cells now, and it works, and we can convert them to stem cells, and we convert those stem cells to eggs fertilize those eggs, and get baby mice that are totally fertile, that grow up and have more baby mice, and then those baby mice have baby mice. There's no reduction in fertility or health with subsequent generations. So we're doing research on that in humans. Now, we're not going to make embryos until we're ready to transfer them. Obviously, we're not going to be ready for a long time, safety testing and all that kind of stuff. I mean, don't plan on this right away. But at least we're able to make oocytes or pre-oocytes, and we're doing that with humans that are perfect volunteers for this, not to get pregnant, but to understand the process better, because I don't think we'll be able to be ready to transfer fertilized oocytes, I'm guessing, maybe 10 to 20 years. But that's certainly a future that is really important. Is you don't have to make stem cells from embryos, obviously, absolutely unnecessary. You make stem cells from skin cells by just incubating in 4 genes, and then those stem cells, it's hard to turn them into organs because that's an organized piece of tissue, but it's not so hard to culture them into oocytes.
Even the mitochondrial work they're doing now.
Yeah, okay, well, that's it. You bring up mitochondrial. I don't want to let that go if you bring it up, because I think if we do a nuclear transfer on a woman who's carrying mitochondrial disease, so that the oocyte has just a normal complement of mitochondria, we can prevent the child from being born with a terrible mitochondrial disease. That's for sure. And I was only one of the authors of that paper. But one idea of transferring mitochondrial to old eggs, I don't think that's really going to be valid. What will be valid is taking a nucleus, and this is working in mice, and we still got to experiment in humans, taking a nucleus from an old egg and put it into an enucleated egg of a donor, and then you get the equivalent of a young embryo. Because I think that the spindle, which gets more brittle and old as the egg gets old, is dependent tremendously on non-nuclear factors in the cytoplasm. But I don't think just injecting mitochondria into an egg is going to do it. But transferring, and it's not just mitochondria, but having the nucleus, the old woman, in a young egg that's been enucleated, fantastic. But we're not ready for that yet, folks. There's a lot of, I think it works in mice and cows, actually, and maybe we'll be doing that in 5 years.
Very good. You've had a couple more questions come through. I don't know if you want to take them. What is mini IVF? I think we've had a few questions around what is mini IVF, if you can just define it.
Oh, well, it's not really the way we do the laboratory work, although it's not a good idea unless you have a perfect lab with absolutely perfect conditions, because you're willing to have less eggs, and so there's no room for error. But on the other hand, it's just a matter of how you're stimulating to get more than one egg, how you're stimulating to get multiple eggs to make it more effective. And if you overstimulate, which is commonly done, you get a huge slew of poor quality eggs with a lot of symptoms and side effects, huge expense, and really a lower pregnancy rate. But if you stimulate mildly, very, very mildly, and the Dutch advocate this all the time, and the Japanese advocate it, and we've been advocating it since 2003, you really do get better quality eggs. And it's just a matter of how you stimulate. So rather than getting, say, 30 eggs and 20 embryos and then doing a biopsy, which we can do, of course, and we will do it in indicated cases, and then finding maybe 1 or 2 embryos that are normal, and then they don't result in the baby either because of the errors in that technology. Instead of doing that, we just want to try to get good eggs to start with, so we have healthy embryos to start with, and that's by not overstimulating. And there are 2 approaches, either the Clomid mini IVF or the Denmark mini IVF. I talked about it a little bit earlier, but you can certainly find a description of it on the website, or you can call us anytime and we'll explain it to you and send information about it.
Or you can call me because I've done it all.
Actually, yeah. You won't believe it. She's volunteered. Anybody out there, any of you can call her.
Absolutely.
She seems to be willing to talk to anybody
Walk
out
you
there.
through.
Find her on Facebook.
Yeah, I know, I'm on Facebook.
You do have one more question. Chin says, please ask my question. I'll be 45 next year, and what is my chance of having twins with mini IVF?
Chance of twins with 45-year-old eggs is very low. Are they younger eggs from earlier? I don't know.
I'm not sure.
Okay, so if she did this and froze her eggs when she's 38, of course she can have twins. I'm not excited about a 45-year-old having twins. I'd rather she have just one at a time. But I can tell you a anecdote. It's very, very uncommon, but we have a friend who is very religious, never used birth control, and had 13 babies, 13 babies, and 45 years of age, and she got pregnant and delivered healthy twins with no IVF, nothing. So we know it can happen. And then one of my first ovary transplant patients, the second ovary transplant we did, it was from a 38-year-old ovary, and she got pregnant when she was 39, when she was 42, and she was 45. No IVF, just got pregnant. And I have a picture with her and her 3 kids, and the ovary finally stopped working, but at age 46. But so it can happen, but I don't want to build up your hopes too much. But I'd rather not have twins. I'd rather just one at a time.
We put in 2 at a time, so I guess the chance is statistically always there that both could take, and at least in our process, we're putting 2 in at a time.
Yeah, I think
We will not be moving forward.
Yeah, I'm just saying.
When you get older, I think you ought to go for one at a time.
Yeah, plus with the complications that I had in pregnancy, my body will not be able to handle
For sure, one
a
at a
multiple
time.
pregnancy. So
I think that's it, unless you guys have anything else.
Well, I'll just say you can go to the website, infertile.com, or you can call the Infertility Center of St. Louis, and we'll be glad to talk to you and answer any more questions.